Please help me welcome Dr. Tejas Sankar.
My lovely wife says I don't smile enough. I'm not sure why, because I think of myself as pretty happy. Maybe, like many of us, it's because I've got too many things going on in my head, from work, to trying to stay healthy, to the economy, to anxiety about AI taking over. But what if you simply couldn't smile? Not because you didn't want to, but because every time you tried, you were struck down by excruciating pain. Tragically, this is life for people suffering from trigeminal neuralgia, or TN for short. TN is one of the most painful conditions known to humankind. People with TN experience severe attacks of stabbing or lightning bolt pain to one side of the face. The pain's often triggered by simple actions we take for granted, like brushing the teeth, chewing, touching the face, and yes, smiling. TN used to be called the suicide disease because in the first half of the 20th century, it was estimated that up to 25% of people with TN died by suicide. Thankfully, effective medications for nerve pain were developed and became a lifeline for TN sufferers, but the problem is not everyone can tolerate these medications. They come with a host of side effects like disabling mental fog, blurry vision, gait imbalance, and also even with 2, 3, or sometimes even 4 different nerve pain medications on board, over time more than 50% of people with TN are going to stop responding to medication and the pain comes back, terrible as ever. As a neurosurgeon, this is where I can help. We've developed surgical operations that work very well in TN. The trigeminal nerve, from which trigeminal neuralgia takes its name, is an insulated cable filled with small wires or fibers running through it, some of which transmit pain signals between the face and the brain. It turns out that about 2/3 of people with trigeminal neuralgia have a blood vessel, an artery that's pushing on the trigeminal nerve. And the constant pulsing from the artery seems to wear down the nerve's insulation, making the pain wires fire out of control. To fix this, I first make a toonie-sized opening in the skull just behind the ear. That toonie is now soon going to be of historical interest. I then gently move the brain aside and journey down a narrow corridor to find the glistening white trigeminal nerve that you can see here and the red artery loop pushing into it. I delicately dissect both apart and keep the artery away from the nerve with a small piece of Teflon padding. Pardon the pun, it's nerve-wracking work. Taking place within millimeters of the brainstem, that part of the brain that keeps people awake and breathing. But it's extremely successful. Most people wake up with their pain completely gone and they can stop taking medication. But unfortunately, there's bad news. In more than 20% of people with TN who get surgery, the pain comes back. Sometimes immediately, sometimes years later, but always with the same devastating effect. Patients are back at square one, restarting medications, living in constant fear of the next pain attack. And surgeons are left frustrated. We wonder why our well-executed operation isn't working anymore. So we wanted to figure out why people with TN so often have a recurrence of pain after surgery. And almost a decade ago, we started an ongoing study, the largest ever of its kind anywhere in the world, which so far has enrolled more than 100 TN patients undergoing surgery. And we've studied these patients before and at many times after their operations. We acquire specialized MRI scans of the brain and trigeminal nerve to see what kinds of changes are happening in both after surgery. Our research is deepening our understanding of TN. For example, using a special kind of MRI called diffusion tensor imaging, we've generated some of the best images ever of the trigeminal nerve and the bundle of small wires within it. The images here show the nerve in 2 patients who underwent surgery. On top is someone who is still pain-free years after surgery, and below is someone who didn't respond to surgery. Now you see, before surgery, both nerves show areas of blue, green, and orange, indicating where the water is moving differently within wires in the nerve. By 1 month after surgery, however, the patient who's pain-free shows obvious changes in the nerve, less orange, less green. On the other hand, there are no nerve changes in the patient whose pain came back. By 6 months after surgery, the difference is even more obvious. The pain-free nerve shows no more orange, no more green areas at all. But in the patient who didn't respond to surgery, the nerve hasn't changed at all. So the bottom line is, if an operation for TN is going to work, it has to cause specific changes in the trigeminal nerve. Without these, the pain is likely to come back soon, even if the surgeon thinks the operation went perfectly, which we often do. Even more interesting, TN changes the brain. The chronic pain of TN makes connections between some parts of the brain stronger and between other parts of the brain weaker. We found that the most important changes are in the connections of the limbic system, which is responsible for fear and emotional responses to pain, and it's shown on the left. It turns out the longer you suffer from TN, the more the limbic system gets disconnected from the rest of the brain, as in the graph on the right. And a disconnected limbic system is bad. It gets ramped up to a state of isolated overdrive, which makes people with TN resistant to surgery. So this finding prompted us to ask, why aren't we offering surgery to people with TN much earlier in their disease, before their brain changes irreversibly? Or taking it one step further, what if you offer surgery as soon as TN is diagnosed? That's what our research team is now trying to find out. The problem is it's hard for people to accept having their head opened except as a last resort. And how can you blame them? Luckily, there's another surgical option, the gamma knife. The gamma knife isn't actually a knife. It's a machine that can deliver a high dose of radiation to a very precise target in the brain, less than a couple of millimeters. We can use this radiation to nuke the trigeminal nerve right as it exits the skull, breaking the flow of pain signals. It's totally non-invasive, totally painless, and the only gamma knife in Western Canada is actually right here at the University of Alberta. After gamma knife surgery, patients go home the same day and they can go back to work the next morning. Studies show that gamma knife is effective in TN, but like open surgery, it's almost always used as a last resort. In a world first, earlier this year, our team launched a randomized clinical trial, which we call Urgent TN, to treat people with non-invasive gamma knife surgery as soon as possible after they're diagnosed with the disease. And I apologize, Adrian, this is a global news clip. I didn't realize, my apologies to the CDC. Anyway, Urgent TN is a completely new way of thinking about treating TN. We're no longer waiting for medications to stop working before we consider surgery. And I'm pleased to say that we've now started enrolling participants. We're predicting that ultra-early gamma knife is going to be a game changer. And it's just one of the ways our research is helping us to get to our goal, to help people with TN smile again. Thanks.